Hello, good evening, and welcome to Let's Talk Cancer. Before I even say anything, I'd like to offer my sincere apologies for the delayed start of this meeting. We were having a bit of technical issue. I hope that as we go along, we'll be able to solve this or get things working smoothly. So I'd like to say welcome once again. Hello and welcome to Let's Talk Cancer. My name is Toyo Idris, and I'm the initiator of LTC, as we call it in-house, or Let's Talk Cancer, and I'm your host this evening. Let's Talk Cancer is a cancer awareness initiative inspired by the loss of a very, very dear friend of mine 3 years ago. Today would have been her 55th birthday, but unfortunately, she's no more with us. I would like to crave your indulgence, everyone that is here on the platform, to please say a prayer for her family, the family she left behind. And I pray that her soul will continue to rest in God's bosom. The week she passed July 5, 2021. I lost 3 people. One was a niece, a 9-year-old to neuroblastoma, that's what's called. I lost a colleague and an aburo who was 42 on July 1st. She died June 29th. July 1st, and then July 5, this my friend passed on. And for me, because I was involved in the care and support of at least 2 of this, my niece and this friend of mine. So it became a burden for me because I knew what I went through, and I felt that this horrible disease, if it's something we can catch, because that's what we're told, if it's something we catch on time, the chances are that we will survive it. Hence, Let's Talk Cancer was born. Our maiden program was on August 23. That was about 2 weeks or 3 weeks after what was supposed to have been her 52nd birthday, was when we did our maiden edition. And then what we talked about was the myth, the facts, all you need, how to detect, how to care, how to support, because then that was what was important at that time. Our second edition, which was about a year afterwards, we talked ovarian cancer, and we partnered with DSI in the US to bring this to those who follow us. And we had a live, we had someone who shared her experience with ovarian cancer. She is living with, I think, 2. She's living with ovarian and another cancer, but she's still alive, and we thank God. Our third was breast cancer, and we had a breast surgeon coming from the UK who shared his experiences and the way around these things and how we can help ourselves and all of that with us. Today, I have the privilege of having one of the best brains in neurology. I think that's what it's called, to talk to us. His name is Professor Olufunmilade Omisanjo. I'd like to say a few words about him, because it's so funny how I met him. I met him treating my dad for his prostate, and I spoke with him just that day. I said, sorry, I have this initiative, this program, this awareness program that I do. If I want you to come on it, would you oblige me? I said, please, just let me know. And that is why we're here today. This was last year, and we are here today having him talk to us. Professor Olufunmilade Omisanjo graduated from the University of Ibadan, Nigeria in 1998 with a Bachelor of Medicine and Surgery degree. He had his specialist training in neurological surgery at the University College Hospital, Ibadan, with a fellowship experience at the, I'm sorry, I can't pronounce this. It's a German. It says, I think it's Universitätsklinikum Gießen, Germany. I hope I got it right. I hope I didn't murder that. And he's a recipient of the German Academic Exchange Program scholarship he was then in 2004. He has had additional clinical exposure in medical centers across the United States, United Kingdom and Brazil, including South Georgia Urology Clinic, Albany, Georgia, USA, Sheffield Kidney Institute, Sheffield, UK, Hospital do Rim und Hypertension in Sao Paulo, Brazil. He's also a fellow of the West African College of Surgeons and an international fellow of the American College of Surgeons. He's also a master's degree. He also holds a master's degree with distinction. I think I need to let us know that the year he did is, he doesn't know I know this. I found this out. The year he did is WAEC. I think he had the best results in the whole of Ogun State then. I just feel like touting his prowess and his ability, academic abilities. He joined the Lagos State University College of Medicine and Teaching, LASUCOM, LASUTH, as a lecturer and a honorary consultant urologist in June 2007. He has wide research interests in uro-oncology and male reproductive and sexual health, and has authored over 60 articles in peer-reviewed journals. Aside his clinical and research duties, Professor Omisanjo has been involved in capital building in several tertiary hospitals across the different geopolitical zones in Nigeria, with particular emphasis on developing surgical skills, expertise in the management of early prostate cancer. Professor Omisanjo is a member of several professional bodies, including the Nigerian Association of Urological Surgeons, European Association of Urology, Société Internationale d'Urologie, and the American Urological Association. He's a professor of surgery with the Lagos State University College of Medicine, LASUCOM, Ikeja, and a honorary consultant urologist and transplant surgeon with the Lagos State University Teaching Hospital, LASUTH, Ikeja, Lagos. He's also the current head of the Department of Surgery at the Lagos State University College of Medicine and Teaching, LASUTH. So, Professor, I would like to welcome you, and I would like to yield the floor to you. You can unmute yourself, sir, while I hand the reins to you to take us through prostate cancer. And I would like to implore everyone that is on this meeting, to please keep muted. If you have questions, please drop them in the chat room. And yes, when you joined, I'm sure you must have had the notice that this meeting is being recorded. Please, just letting you know that it's being recorded so that you're aware of this. So thank you very much, everyone, for joining us. And I hope that by the time the Prof is done with his presentation, we would have gained something. And then we're still going to come up with another guest who is going to share his own personal experience with cancer. And I hope at the end of today, we will all have been positively impacted. Thank you very much. Prof, over to you. Hello, House. I'm sorry, everyone. It looks like Prof is having a bit of challenge with network. It's been going on for a bit because we've tried a couple of times before the meeting started to get him to have things, all this sorted, but it seems maybe his location right now has some challenge. Okay, while we wait for Prof to come back on, I think I would like to bring on my second guest so that at least we keep moving. My second guest. Okay.
Mrs.
Yes,
Prof. Can you
hear
me now?
Yes, we can hear you.
You know.
Yes, we can hear you.
Sorry, I've had to leave. I think there's a connectivity problem suddenly in my office, and I've had to be changing location.
Okay.
So, if you can hear me, yeah.
Yes, we can hear you. I can hear you.
I was just driving to another place. Okay, so fine. If you can hear me, then
yes, we can hear you.
I think I'll just.
So I'll share from here.
Okay.
Then let me share from here, and then.
Okay.
Okay. So your slide is up, and you have the floor, sir.
It's just I can't see myself. Okay, you just fly along, right?
Yes, I'll flow along with you.
Okay. All right. Good evening, ladies and gentlemen. Sorry for the issues with internet connection. We had done a trial run with Mrs. Idris earlier. So thank you for having me talk about this topic. You said we'll be talking for like 30, 40 minutes.
Yes, please.
So we'll be talking about prostate cancer, and I'll try to stay within that period. General points about the prostate. Every male child is born with a prostate. And at the time of birth, it's just about the size of a peanut, and then it starts getting bigger as people get older. The reason why we usually talk a lot about prostate issues, prostate cancer especially, is because as people get older, prostate issues become more common, and the benign prostate enlargement and prostate cancer are the two most important diseases of the prostate that we have to deal with. The prostate is basically, like I said, the peanut-sized organ that is at the base of the bladder at the time the child is born. And the tube that carries urine from the bladder through the male organ out runs through the substance of the prostate. And that is why as the prostate gets bigger, men generally will tend to present with some form of urinary symptom or the other. The average prostate at the time of puberty will weigh about 20 grams, about the size of an average sized kola nut, or what we call walnuts here, not the European walnut, what in Yoruba they call that salad. But so roughly that size is what the adult size is. The prostate, it's what we describe as an accessory sexual organ. So it's not something that is a necessity for a man to be sexually active, but it does play a role in secreting part of the human ejaculate, and there are a few enzymes in it that help to maintain sperm vitality. So that basically is the function of the prostate. As people get older, like I said, the two most common disorders of the prostate that people get to have are the benign prostate enlargement, which is not the focus for today, and the malignant enlargement of the prostate, what we call carcinoma of the prostate. And the picture you have there that's labeled A and B compares what the normal flow pattern is like in a patient, in a man who does not have prostate enlargement and in a man who has prostate enlargement. So if you look at the picture B, that blue arrow shows a thoroughfare through the substance of the prostate, which is what you expect normally. But as the prostate starts to enlarge, it kind of squeezes up the tube that runs through it, the urethra, and then all sorts of challenges with pain can then come up consequent to that. The next picture is just a pictorial show of how we get to examine the prostate, with the doctor putting his finger gently in the back passage of the client and then having the feel of the prostate first to know whether it's enlarged. Is it enlarged? Is it smooth? Is it hard? Does it have nodules? Each of these with its own implication for diagnosis. The other test we usually do for prostate to assess the prostate is the PSA. I'll come to that in a minute. So talking specifically now about carcinoma of the prostate. Prostate cancer globally is the second most common cancer, but in Nigeria, it is the #1 cancer in Nigerian men. It's interesting to note that in North America generally, at least 80% of men who have prostate cancer will come with local or regional disease. What I mean by that is early disease. And the importance of that is essentially 80% of those patients will have the opportunity of being cured. Because when somebody has prostate cancer, if it's early, there is a very good chance of a cure. The next slide compares the pattern in the US with what we get in Nigeria. at least 75% of patients in Nigerian hospitals who come with prostate cancer will already have locally advanced or metastatic disease. By metastatic disease, we mean disease that are spread to distant sites. And so it's the kind of what you call like a double whammy situation. So it's in the part of the world where it's in those parts of the world where we have the worst in terms of facilities, access to care, that we see the worst of cases. It's pretty sad. And 95% of cancers, prostate cancers that we see, will occur in men who have that age bracket of 45 to 89 years. There is a slide on epidemiology and statistics, which gives an idea of the number of men that we lose to prostate cancer. One of the earliest studies that gave an estimate of the hospital incidence put it as 127 per 100,000, meaning 127 of every 100,000 patients who comes to the Nigerian hospital has prostate cancer. And the annual death in Nigeria years ago had been put as at least 20,000 deaths per annum. There's a slide there again that gives an idea of where Nigeria ranks amongst neighboring nations, if you could say that. Even when you correct for population, Nigeria compared to our neighboring countries, Ghana, whether it's Gambia, Cote d'Ivoire, Senegal, we have the highest prevalence rate, we have the highest mortality rate. In 1969, Professor Zunkwansong and Lawani did a study on prostate cancer incidence. And as at 1969, prostate cancer ranked as the 8th most common cancer in Nigerian men. And they concluded in that paper that prostate cancer was not a common cancer amongst Nigerians. Fast track 3 decades down the line, 1996, in the same institution, Professor Gumbi and Shitu did another work where they then found that as of 1996, prostate cancer had moved from the number 8th position that it was in 1969 to being the number 1 cancer in Nigerian men. There are all sorts of reasons that people have tried to bring up to explain this. People think it's lifestyle, the fact that our lifestyle has, because back in the days, people will say prostate cancer was more of like the disease of Caucasians rather than a black man's disease, and that as we have over the years adopted a more Caucasian lifestyle, that has been one of the downside to that. But the counter argument is 30 years may not be enough to show that kind of pattern. But one thing is clear, we are beginning to pick more prostate cancer cases, because everybody will know in 1969 how many hospitals did Nigeria have then, how many doctors and all that. And so whether it's the fact that we are picking prostate cancer more than before, whether it's because people are now more educated and they show up a little bit more, whether it is because in actual fact, our way of life has now kind of become a much stronger risk factor for the development of prostate cancer, the argument continues. But what is clear and incontrovertible is the fact that prostate cancer is now the most common cancer amongst Nigerian men. And I share with you one of the more recent studies from whether it's from Abuja or from Abuja and Ibadan. Both of them recorded prostate cancer as the most common cancer amongst Nigerian men, with an average age at the time of diagnosis of 68.2 in the Ibadan group and 66 in the Abuja group. Late diagnosis is still the norm in Nigeria. Most Nigerian men who come in with prostate cancer will come in when the disease is already advanced. And one of the studies done in the South-South region showed that at least 2/3 of the patients that presented already had diagnosis. And there's a line there on the relatively high PSA that most of our patients have at the time of diagnosis. So again, if you look at the European, North American axis, most cases of prostate cancer that will be diagnosed with a PSA less than 20. The average PSA at the time of diagnosis, in Nigeria has been put at around 100 nanograms per ml. What that means is, again, that most of these cases at the time of diagnosis are already advanced.
Sorry, we're not seeing the chat, please.
Okay, that's okay. This is Idris.
The chat is on. It's been shared. Sorry, who's unfortunately I can't control, but it's been shared on the screen right now.
Yeah, quite a number of people are not seeing.
May I ask?
Can you switch on your? Yes, please.
So could you check your view? Because if you're the host, if your view has pinged you, then that's probably why we're seeing you. But if you check your view,
you are seeing me.
Yes, you are the only.
Yeah. Okay. I didn't know that.
Ping yourself.
Yes, I know that. Yes, I know that. I think that must be it. Hold on. Thank you for that, Abimbola. Thank you.
I'm not complaining. We enjoy seeing your face, but what also say the slides.
Okay. Okay. Oh dear. Oh no. The plan wasn't that I would oh, now I see. That's why.
So I can continue.
Please continue.
Okay. Yeah. So across the various geopolitical zones of Nigeria, the story is the same. Patients present late. But that's just one side of the story. The slide that's being displayed now is a slide that gives you an idea of what we call the waiting time for diagnosis, which is a measure of the efficiency with oncological services in different settings. So you have a patient who is coming to the hospital late, but in spite of the fact that the patient has come in late, within the healthcare system, there is still another delay. And so the median waiting time for diagnosis of prostate cancer in Nigeria, from studies that we have done and published in Nigeria, actually showed a median waiting time of about 13 weeks, which is about twice what it is in Canada, Poland, and a few other centers in North America. But of course, our figures are comparable to some of the areas in South Africa. The problem with this is then that, one, the patient delays in coming, and even after the patient then gets access to care, there is another delay within the system. We've tried to analyze that, and the delays occur within the system at various levels. Sometimes it's from the point of the patient showing up at the hospital and seeing a consultant. You know the issues we have with the doctor-patient ratio in Nigeria, which is a lot worse when you then look at specific specialties and all that. That is one level of delay. Even after the patient makes contact with the specialist, usually to make a diagnosis of prostate cancer, the patient will need to have a biopsy done, will need to have an MRI done, depending on, so you're talking about access to, prostate biopsy services, access to radiological services. There are states that still have only 2, 3, 4 centers for MRI, those kind of things. So that's another level of delay. When you do the biopsy, the sample has to be sent to the lab. The pathologist processes will process the sample. He reads, he examines them, all that. So every single step of the way, there is potential delay. And so not only is there a delay in the patient presenting, even in making the diagnosis, there is still a delay. And the next set of slides you see are just pictures of PSA levels that people are presented with. And these are real patients that we saw in our own practice in LASUTH. So you have a patient coming in for the very first time with a PSA of 1,311. That's the patient's result. That's not picked from the internet. The next one, another patient came in with a PSA of 2,370. And if you check in the left upper corner, the clinical history of that patient actually reads health check. What that means is this was a supposedly fine gentleman who had no complaints, just walked into some lab that he wanted to do a check, and his PSA came out as 2,700. Of course, not only did that man have prostate cancer, his prostate cancer had metastasized. It's amazing the kind of things Nigerians, we can cope with as Nigerians, not just economic hardship, you know, the extent of disease that sometimes you will expect to have ravaged somebody's body. A Nigerian just manages to still cope with it, and you ask him, and it's fine. I don't know if that's a good thing or a bad thing, but you know, we just seem to be able to cope with a lot, whether it's financial hardship, medical hardship, and all that. And so those are the kind of figures we get. The next one, 1,915, and that's another one, greater than 15,400. Again, these are real values of patients in our clinic. Of course, this particular gentleman, he had been everywhere, and people had been making all sorts of diagnoses until at some point somebody was like, you know what, let's just do his PSA. And that was the figure that we got. What are the causes of prostate cancer? To a large extent, we do not know. And that's the summary. The only consistent thing about prostate cancer that we say are, I mean, the consistent things that we say are risk factors are race, age, and then, of course, family history to some extent. I'm sure most of us will have read about things like, we talk about, fatty diets, you know, things like red meat will increase the risk, vegetables like tomato will decrease the risk, and all those, and all that. Those are best qualitative things. The ones that are consistent are one, race. So, two, age, and then family history. So the disease tends to be much more common in Black men compared to Caucasians, compared to Asians. And again, we know it's a disease that is hardly diagnosed in men who are less than 40 years. And so as people get older, the risk is there. A family history is also a risk factor, especially when it's a first degree family member that got the diagnosis. So a brother, a father, that sort of thing. So these are the major risk factors. Unfortunately, these are risk factors that we cannot modify. Like I said, there are other less important ones like diet and, you know, lifestyle. So so to summarize the risk for prostate cancer, if you go down the slides, will be one, age. 80% of prostate cancer cases are diagnosed in men who are over the age of 65. If you go down the slides, Mrs. Idris, and then there is a higher incidence, and the mortality rate is a lot higher amongst Blacks, whether that's African Americans or Blacks, anyway.
Prof, I'm having challenges with the slides. It's not moving anymore, but so I think you just have to keep
Do you want
going.
me to continue?
Yes, just keep going until I get it back on. All right, thank you.
Okay. And then you catch up. Oh, okay. So the men who are at risk for prostate cancer are one, Black men. Again, prostate cancer can occur in men of any race, but it is a lot more common in Black men. A man who has a first degree relative, who has a family history, and the important reason why we mention this is we need to know what's going on with our folks. The way we are as Nigerians, you know, people don't talk about, you know, we don't discuss our medical history. We just don't. And then, you know, we have this bit of, even if a family member dies, it's like, oh, that person is gone. Whoever is gone is gone. As we were saying in this part of Nigeria. The truth is, yes, whoever is gone, but, you know, there may be some genetic connection between the person who is gone and those of us who are still behind, which is a very important reason why we need to know what's going on with our folks. And that family history becomes even more important if it occurred in a male younger than 65. Just this morning, I still saw actually two brothers with the same diagnosis. An interesting, story was the younger one that we diagnosed first, and his elder brother, who had always been close to him, was the one bringing him to the hospital and all that. 2 years down the line, he never checked until he started having a few symptoms, and he then went and did his PSA, and lo and behold, it was quite high. And so we have that story. Sometimes siblings, same father, same mother, who will have prostate cancer, and you will have to just sort them out. It's just that, yes, when you pick this early, the results generally are better than when people wait till very late. So this is a slide. The next slide gives one an idea of the risk, the lifetime risk of developing prostate cancer. So at the age of 45, the risk is about 1 in 2,500. By the time a man gets to the age of 70, 75, at least 1 out of every 10 men will have prostate cancer at that age, irrespective of the population that you're looking at. So what are the symptoms of prostate cancer? In the earliest stage of prostate cancer, there will be absolutely no symptom. And that is an issue. You have a gentleman who is fine going about his business, and then somebody says you should do a health check. You see a PSA that's, you just see a value that's you're not very comfortable with, maybe slightly out of range. You're like, okay, let's monitor. You repeat, it's still, just slightly out of range. And you tell him to do an MRI. The MRI shows something suspicious. You do a biopsy and you say it's cancer. It is sometimes very difficult for people to accept that diagnosis at that stage because there is absolutely no symptom. Unfortunately, that is when it is really curable. So in the earliest stage of prostate cancer, there is absolutely no symptom. When people then develop symptoms, they have what we call lower urinary tract symptoms, which are like a constellation of all sorts of symptoms relating to difficulty with voiding. So we usually will say that avoiding symptoms and storage symptoms. So avoiding symptoms, like the patient may notice that he has a poor stream. The force with which his urine comes out is reducing. He may notice he has intermittency. His urine is not able to come out in just one flow. A little bit comes out, it stops, a little bit comes out, it stops, that kind of stop and start sort of thing. Sometimes the patient tells you, oh, each time he voids, he still feels as though he has some urine left in there, what we call feeling of incomplete bladder emptying. Sometimes what the patient has is training to void. Sometimes it's what we call hesitancy. So the gentleman gets to the restroom and he has to, say a word of prayer, before, the urine comes out, waits for sometimes, 30 seconds, 1 minute. In fact, sometimes a few minutes before the urine begins to come. All of these are voiding symptoms that patients can have. Sometimes it's the ones we call storage symptoms. The patient is beginning to wake up, to pee urine, to pass urine frequently. Sometimes it's daytime frequency. Most people should be able to hold urine and pee at least 3 to 4 hours apart. Some people just can't do that. They pee every two hours or less. That is frequency. Sometimes it is urgency. Now, the first time one feels the urge to pee is not necessarily the time we all pee. Most people will be able to hold it until they get into a convenient situation, then they go pee. But when somebody has urgency, the very first time he pees, he just has this very strong urge to go. And sometimes if he doesn't go, the patient goes on to pee on himself. That's what we call urge incontinence. Now, all of these are symptoms that can occur in prostate cancer. But the catch is this: all of these symptoms can also occur in the non-cancerous type of prostate enlargement, what we call BPH, the benign prostate enlargement. So there is none of these symptoms that is, as it were, specific for prostate cancer. These symptoms can occur in men who have the benign form of prostate enlargement. They can occur in people who have prostate cancer. That is why you just never can tell. Unfortunately, again, men will talk. You have Mr. A has this symptom, he used something, he got better. So when Mr. B has his own symptom, he doesn't want to go to the hospital, understandably so, to use the same cocktail of meds that his pal has used. It gets better, not knowing that what those medications have done is just to help with symptomatic control of his issue. The primary diagnosis, which in his own case may be prostate cancer, will continue. And that is why the most important thing is that people should have a low threshold for seeing the necessary specialist. Even in people who have symptoms, the early symptoms are indistinguishable, cannot distinguish between prostate cancer and the benign form of prostate cancer. What is more, there are other conditions other than prostate enlargement that can cause these symptoms. A straightforward urinary tract infection can cause this. Women who do not have, women don't have prostate. Women can have urgency from an overactive bladder. Sometimes it's a bladder stone. Sometimes it's a neurogenic bladder. Sometimes it's something as simple as the fact that the man is snoring. That's why he's waking up to pee at night. Sometimes it's an antihypertensive med. So you have a host of reasons why all these symptoms can occur. So you can't use the symptom again to make a specific diagnosis. But the catch is that anytime a symptom occurs, one should do the needful, which is have a proper check, have a proper analysis to know what is causing this symptom. When this is not picked, other symptoms can occur. Things like hemospermia. So a man may begin to see blood in his ejaculate. Yes, that can be due to prostate cancer. It can be due to some other things. The man may find out that his ejaculation becomes painful for him and all that. So these are some of the symptoms people can have from prostate cancer. And then, of course, people can have symptoms of metastasis, meaning, symptoms of spread of disease. That can be something as simple as the man becoming tired unnecessarily because his blood levels are becoming low. Sometimes the person can come with what we call paraplegia, which is paralysis of the lower limbs. Now, that usually will not occur suddenly. In a few instances, it does occur suddenly. But in most men, it will have been showing us some sign of low back pain. Again, unfortunately, the vast majority of men who have low back pain will not have prostate cancer. And so, sometimes the back pain is from, the way people say it is just something muscular. It's just from a sprain. Sometimes it's from lumbar spondylosis. It's from a host of other things. But sometimes it could also be from prostate cancer that has spread to the bone, because the commonest site of spread of prostate cancer is actually to the spine. And we have had people that the very first time they were diagnosed with prostate cancer was when the man just stood up and got up from bed, and that was it. He fell simply because his legs could no longer carry his weight. When prostate cancer spreads to the bone of the back, what it does is to destroy the bone gradually, and someday, whether it's a sudden movement or something as simple as standing up, the weight just crushes the bone completely, and that squeezes on the spinal cord. And once the spinal cord is compressed, usually what the person has is paraplegia. Sometimes you're able to reverse that. Sometimes we can't reverse it. Of course, if it spreads to the lungs, people are already having, difficulty with breathing and the likes. We've also had men that you just had somebody who wasn't a known epileptic as an adult, just started having seizures. And that was when we found that he actually had prostate cancer that has spread to his brain. So these are some of the symptoms that people can have. To establish a diagnosis of prostate cancer, usually you talk to the patient, you take a history, we do a physical examination, and we do the necessary investigation. The basic assessment of the prostate requires, it's on a tripod of things. One, we do a digital rectal examination, which is just the picture we displayed earlier. That's just a doctor putting a finger on the patient's back passage to have a feel of the prostate. That's the way the prostate feels when it's benign. That's the way it feels when it's malignant. The second test we do is a blood test called the prostate-specific antigen, PSA. The normal value is usually between 0 and 4. Any value above 4 raises suspicion of prostate cancer. Now, it does not mean that everybody who has a PSA above 4 will have prostate cancer. But so if the PSA is below 4, we can give that 99% assurance that it does not have prostate cancer. Once the PSA is above 4, you can no longer give that level of assurance. It means there is a chance there is cancer in that prostate. The higher the PSA, the higher the chances of him having prostate cancer. And that is why we always will tell people to check that. So the next test we also do is an ultrasound scan of the prostate. So those are the 3 basic things we do. Now, if all of these 3 tests are consistently suggestive of a benign prostate, you take it as that. Of course, you do have the occasional patient who will have everything, all the tests being suggestive of a benign prostate, yet the man has prostate cancer. That's an exceptional case, and we have few of those. But most of the time, if all the three tests are consistently suggestive of prostate enlargement that is not cancerous, then you take it as such. You take it as benign prostate enlargement. But once one of them raises suspicion, whether it's the digital rectal examination, the prostate-specific antigen level, or the ultrasound, once there is a suspicion of prostate cancer raised by any of these three, you must then go on, you must then escalate and do the next level of test, which is now magnetic resonance imaging and a prostate biopsy. Those are the two tests we usually would then do to make a diagnosis of prostate cancer. It's important to know that besides prostate cancer, other conditions that can lead to elevation of the PSA, something as simple as inflammation of the prostate, prostatitis. So sometimes if a man comes with an elevated PSA and you suspect, oh, this might be due to prostatitis, the first thing we do is place him on the course of antibiotics for a couple of weeks and you repeat the PSA, and you see if the PSA has come down to normal levels, you can safely
I think you're muted, Professor Omisanjo. We can't hear you again. I think you have. I think maybe
it's not muted. I mean, but it's not muted, please.
It's probably network. He's been thrown out. He will come back.
It is
Yes,
network.
yes.
Don't worry.
Okay. Yeah,
that's the challenge we've been having all day. Thanks.
Okay.
Hello? Sorry. Hello?
Yes, you're back.
Am I back?
You. Yes, you're back.
Yes, you're back.
I'm back, right?
Yes.
Yes, you are. We can hear you clearly.
Sorry.
It's okay. Please
Sorry.
go on.
So I was talking about, I think you went up when I was talking about the PSA, right?
Yes. Yes.
Yeah, I was saying there are other conditions besides prostate cancer that can lead to an elevation in someone's PSA. So when the PSA is below 4, yes, almost a 100% guarantee that there is no cancer. Of course, we have some exceptional cases of prostate cancer, even with a normal PSA. But usually, when the PSA is within normal range, we can give an almost 99%, 100% guarantee that there is no cancer. Once the PSA is above above 4, then there is a risk of cancer. The higher the PSA, the higher the risk of prostate cancer. And I did say that something like prostatitis may sometimes be the reason why the PSA has gone up. So sometimes if you suspect the patient has prostatitis, you see an elevated PSA, that's not too high, something in that range of 4 to 10, because the normal is less than 4. 4 to 10 we take as a gray area. So somebody comes with a value of like 7, every other thing looks benign. Yes, sometimes we do a course of antibody and then you change down you check the PSA again to see whether it's normalized or not. If it's normalized, you can reassure the patient. If it's still elevated, you must then go on to still do you must then escalate and do the necessary tests, which I said are 2 tests mainly, an MRI and then a prostate biopsy to confirm if indeed there is prostate cancer or not. There are medications that people may be on that may actually give a falsely low PSA level. So men who are on injections like Zoladex for other conditions, finasteride, if they don't disclose it, you have a patient who has a PSA that on the surface of it looks normal. But if you then correct for the fact that he's been on a potentially PSA lowering drug, you will then know that his real PSA is actually higher than what the test result reads. And one may need to then escalate and rule out prostate cancer in that case. There are different modifications of PSA we do depending on the patient. And I will tell you why. I did say that there are other conditions that can lead to PSA elevation, even BPH itself, especially if the BPH gland is very huge. So to take care of the bigness of the gland, what we sometimes do is to calculate what is called the PSA density, which is you divide the PSA by the size of the gland. The PSA velocity is important for people who are having regular checks. So a PSA value of 1 is normal, a PSA value of 3 is normal. But if a patient goes from a value of 1 to 3 within the space of 6 months, 1 year, that is abnormal. That rate of rise of PSA is what we call PSA velocity. You don't expect the PSA to rise higher than 0.5 nanogram per mil per year. So that is why it's also important to do regular tests. So not only, it's not just the absolute PSA value that is important, the trend of the PSA is also something that is important in diagnosis. The ultrasound scan we can do through different approaches. I want to rush through this so that we'll have more time for questions. So there are specific things you can see on ultrasound that can raise one's suspicion for prostate cancer. If the capsule is irregular, if the prostate is heterogeneous and all that, all of these are things that will raise suspicion for prostate cancer. And once there is that suspicion, whether it's based on the PSA value, the DRE findings, the digital rectal findings, or the ultrasound finding, we must go on to do a prostate biopsy. Once the prostate biopsy confirms prostate cancer, we have a host of investigations we do to stage the disease. What that means is you want to know the extent of the disease. So is the prostate cancer still confined to the prostate, or has it spread out of the prostate? And if it has spread out of the prostate, how far has it gone? Is it still in the, local, is it still in the vicinity of the prostate? So is it still in that local area, like has it just spread to the surrounding structures like the seminal vesicles, the rectum, the bladder, and the likes, in which case you say it's a locally advanced disease, or has it gone to distant sites like the bone, like the vertebrae, like the lungs, like the liver, like the brain, in which case we say it's metastatic. Because the treatment of the condition will depend on the stage of the disease. Now, depending on the stage of the disease, what we may do is just what we call watchful waiting or active surveillance. So you then wonder, what that means is you are not instituting any specific treatment. Why would you want to do that for prostate cancer? It's because in the early stages of prostate cancer, remember we said that is a cancer that is confined to the prostate. We do what we call risk stratify the patient. So some of them will have what we call low risk early disease. Some will have intermediate risk early disease. Some will have high risk early disease. The reason why it's important to stratify them is this. We do know that there is a subset of early prostate cancer that tend to be indolent. There are cancers that are so slowly growing that we say the patient dies with his cancer rather than from his cancer. So that sort of patient, all you need to do is to put him on a monitoring regimen that is called active surveillance. You monitor his PSA, you do repeat MRI. Sometimes you need to repeat his biopsy to be sure that the pathology of the cancer has not changed. Because part of what the pathologist will report is not just that this patient has cancer. It gives you a score, what we call the Gleason score or the ISOP score, that gives you an idea of the aggression of the tumor. So the not too aggressive one, you actually can do an active surveillance protocol for the patient, which is just to monitor the patient. But once it is at least the intermediate or high risk disease, the patient must have treatment. And there are curative treatment options for the patient. One is surgery, that we call radical prostatectomy. Another one is radiotherapy. And then there is what we call LIFO, that is what is called cryotherapy. The surgery can be done, of course, I'll come back to the surgery in a minute. Once it is advanced, that is when we start talking about use of different methods to control the hormonal, to change the hormonal milieu of the patient, to, as it were, reduce the amount of testosterone that is available to the prostate. Now, testosterone is something that is useful for prostatic growth. When, unfortunately, a man now develops prostate cancer, the testosterone cannot differentiate between normal prostatic tissue and cancerous prostatic tissue. The testosterone feeds both. So the testosterone that is a good thing normally in a patient who doesn't have prostate cancer becomes a bad thing in a patient who has prostate cancer, because the prostate cancer feeds off the testosterone. If the patient comes at the time when you're able to take out the prostate, you don't need to bother about his testosterone. That surgery will cure him. But once the patient has a prostate cancer that has spread, you must institute some form of treatment to reduce the testosterone. That is why most of you will have heard of men who have to lose their testes as part of the treatment of prostate cancer. That need not be so if the patient comes in early. And then, of course, for people who can afford Zoladex, that is, of course, an alternative. So we have all these different treatment options. I think I'll skip them. That should not be the focus for today. For surgery, we can do the surgery open. We can do it laparoscopically. The laparoscopic one can be robotic, can be non-robotic. The most important thing to note is this: whether you do the surgery open, laparoscopic, non-robotic, or robotic laparoscopic, in terms of oncological outcome, is the same. That is, in terms of the chances of the patient getting a cure, the chances are the same. The only difference between all these surgeries will be the risk of side effects. The two side effects we dread most when you have to do surgery or indeed radiotherapy for prostate cancer are loss of erection or urine leakage. And there are suggestions that, yeah, depending on which one you do, one may preserve the erection better than the other, but the debate is ongoing because some other studies have shown that really there's no advantage in preserving erection with one compared to the other. The major advantage of the robotic method and the laparoscopic method will be shorter hospital stay and less risk of blood loss. And so these are the various options for treating prostate cancer. I will round off with this. It is important to ask the question, can prostate cancer be prevented? Because that would be the main purpose of a talk like this. Yes, to some extent. The things that people have talked about are chemoprophylaxis, which is use of medication, screening, diet, and lifestyle modification. Diet, most people will say cut down fatty diet, cut down carbohydrates, cut down red beef, cut down animal protein, do a more vegetarian diet, try and do at least 1 tomato per day and all that. Lifestyle, exercise, don't live a sedentary lifestyle. But you'll agree with me, those are the same set of things your cardiologist will tell you is good for your heart, the nephrologist will tell you good for your kidney, somebody will tell you is good for preventing diabetes. And what is more, whatever lifestyle pattern we all adopt, all of that can be overruled by our genetic makeup. And that is why we should not get carried away that because we live in healthy lifestyle patterns, people cannot be afflicted by this thing. But at the best, at least we will still always advocate for healthy lifestyle, healthy dietary pattern to be adopted by people. Use of medication to prevent prostate cancer is not very popular. We have a group of medication that now show, yes, the absolute number of men who develop prostate cancer while on this medication may be lower than for men who do not use the medication who go on to develop prostate cancer. But for the few men who go on to develop prostate cancer while on this medication, they tend to develop the very aggressive one. That is why the use of medication for preventing prostate cancer has not been adopted on the public health scale. So screening is what most people talk about. Why do we talk about screening? If you look at the slide for argument for screening, the major thing about screening for prostate cancer is that when you detect prostate cancer early, treatment is associated with a better outcome. But there are arguments against screening. The fact that some prostate cancer can be indolent, and people then say that, look, you are making the treatment of the disease worse than the endurance of that disease. Remember, like I said, sometimes with treatment, people can have side effects. In fact, there is always a mortality rate for any major surgery that is done. The mortality rate is very low, very extremely low anywhere in the world, but there will always be some men who will die from surgery anywhere in the world. So people argue that this is a man living his life, you go make a diagnosis, in the process of treating him, something happens to him, and then he dies earlier than he will have died if maybe he didn't seek treatment for his prostate cancer. But it is not always that simple because you can always use 1 or 2 or 3 cases to generalize. So there had been some controversy about screening. So there was about 10 years ago, the United States Preventive Service Task Force came up with a statement discouraging screening in the US. And so for years, people were discouraged, doctors were discouraged from screening men for prostate cancer. But the American Urological Association, which is the body that speaks for urologists in Nigeria, in the US, actually spoke against that. But again, it's like you have a government arm speaking against a professional arm. So that bit is still ongoing. But the European Association of Urologists always say that men who are at risk for prostate cancer should undergo screening if they are above 50 years if they are black. And the last time I checked, 99% of Nigerians are black. So you have people who will talk about the various arguments for and against screening, but the argument, the conclusion generally tilts in favor of screening in a Nigerian population. And I share with you this slide about our experience with screening. We've not had any large-scale screening in Nigeria, but the Lagos State government did some screening a few years ago, and we were able to look into the data which we published. And they went into communities, looked at men who were fine, who had absolutely no complaint. 1% of those men had prostate cancer. Now, over 4,000 men were screened. 1% of that came to over 40 of them who had confirmed prostate cancers. These were men who were sitting in their houses, supposedly fine, and at least 5% of them already had advanced disease. Okay, so the challenge is people sometimes assume that the experience, the American or the British experience, is what we will find in Nigeria. When screening is, when those days when people were doing a lot of screening in the UK and in North America, most of the cases of prostate cancer they found were early prostate cancer. But the little bit of screening we've done in Nigeria has shown that when we do screening, most of the cases are advanced. So the point is there is still a valid argument for screening for prostate cancer. As a roundup with the last 3-4 slides, anytime we talk about men's issue, especially prostate cancer, I like to remind people that as men get older, there are different things that can come up, what we will usually call andropause, like women attain menopause. So men above the age of 50, 60 can have all sorts of hormonal changes that we usually call andropause, can manifest as erectile dysfunction, loss of energy. Some of them then become at risk. The risk for developing things like diabetes and all that become higher. So as we talk about prostate cancer, we always encourage men to look at all these other aspects of their life. It is important that men remember that as they get older, there is need to always have a health plan. You can't always do what you used to do as a young person. As people get older, a man needs to anchor his health on at least the GP. And we say in medicine, the body is always a struggle between one's nature and one's nurture. You do the best to nurture yourself, exercise, do all these things we say, but we should know that sometimes our genetic makeup may just be such that whatever we do, some of these things will happen. But the most important thing would be to pick this thing early. And again, it is always good to have a health plan anchored by a GP who can always help people and guide them as to what to do. So my last slide, take-home points. Prostate diseases are very common amongst men who are above 50. Prostate cancer is the most common cancer in Nigerian men. We all pray, we all do these things, but there is nowhere you will go to if you see 100 Nigerian men who are above 60. What statistics tell us is over their lifetime, about 5 to 10 of them will develop prostate cancer. That is statistics. We can always talk about the other side of things and all that, but that's reality. So prostate cancer is very common, is the most common cancer. But a more important point for me is the fact that we need to take away from this, the more important point we need to take away from this discussion is prostate cancer is curable, eminently curable if it is picked early. That's the caveat, if picked early, which unfortunately is not the story of most Nigerian men who have prostate cancer. And a program like this is aimed at changing that paradigm. There has to be a change. And the only way we can diagnose prostate cancer will be for us to do screening. And that's why on that last slide, I have screening, screening, screening. We must encourage men to screen. And I've had a few female voices on because of the program. I get excited when I see women listen to this kind of thing, because generally I think they tend to keep these things better in their hearts than men. What I always tell people is, you have a man in your life in whatever capacity is above 50, is not at the prostate screening, his next birthday gift from you has to be a prostate test. Whether you now include that as part of a trip to somewhere, you give him a holiday, take him to a golf course, a man above 50 who has not had prostate test, his next birthday gift has to be that. And the very last point I will make is advocacy advocacy. And why do I say that? When we screen men, some of them will have prostate cancer and they're able to treat themselves. Some people have the resources, but we have a sizable number of our men who will not have the resources to treat themselves. Who takes care of them? We need more players in the prostate cancer field. I know there are so many other things people need to sort out, but somebody has to speak for this man. And I leave you with this real life story. Several years ago, just coming into LASUTH, I had a patient who he had metastatic disease. We started him on some medication. He was doing well on with his medication, and then I didn't see him for some months. And then he showed up. His PSA had gone up after an initial drop. And then we started discussing. I tried to find out why that was so. Of course, sometimes, even when a patient has been regular on his medication, the PSA can start going up. If the patient has developed what we call castrate-resistant prostate cancer, you then need to switch treatment. But sometimes it's because the patient has changed his brand. Sometimes, it's just that it's just not working. I started probing, and then the man brought up the sheet from his back, and he said, that's why. I said, what do you mean, sir? And he showed me the graduation list from one of the first generation Nigerian university.